Daryl Baskin here again, San Antonio Ophthalmology Course, continuing on with the other retinal vascular diseases section. This is a patient that I took care of in Burundi with retinoblastoma. You can see here, this is just with an iPhone camera looking around. Really sad cases there. There's a tremendous need for better eye care in sub-Saharan Africa, in many parts of the world, but I know firsthand from sub-Saharan Africa. I look at this picture a lot. I took this picture, but this picture is representative of the scenario in many parts of the world where we have the patients, but we don't have the doctors. So if you get a chance to volunteer and do it the same place over and over again, I think that's very helpful, and do it in a place that can take the most advantage of your talents. That's the anesthetist that I work with a lot, Joseph. We gave these kids ketamine. So, all right, so sickle cell disease. And I don't have a lot of firsthand experience with this. So this is going to be more book knowledge. So this is the most common inherited blood disorder in the U.S. Autosomal recessive disorder affects 1 out of 400 black people born in the U.S. Importantly here, the most likely to cause proliferative retinopathy is going to be hemoglobin sickle cell C, or hemoglobin SC disease, more so than S-thal, which is second, and then more so than SS disease. There are sickle cell preps. They're reliable indicators of the presence of hemoglobin S. It's good for screening. Don't distinguish between heterozygous and homozygous states. If they test positive, hemoglobin electrophoresis should be done. All black patients with a traumatic hyphema should be tested. Here are the different stages that they list. I don't think anybody would test you on what is a stage 5 sickle cell retinopathy, but it does have there's a staging scenario out there. Stage 5 is TRD, stage 3 is NV. And then name this lesion. These are pictures that I have from one of my mentors, Bill Benson. This is a black sunburst lesion. Some more black sunburst lesions. Here's a patient. Remember the Pepsi thing, Pepsi B. The S in there was for sickle cell. You see the angioid streaks here. Oh, there we go. 6% of patients with SS disease have them. Name these lesions. So we've got refractile spots, old resorbed hemorrhages with hemosiderin deposits just beneath the ILM. And then this one is a salmon patch hemorrhage. It's a retinal hemorrhage that occurs after a peripheral retinal arterial occlusion. Here we see the CFAN. It differs from PDR in that it's usually more peripheral, and it also may auto-infarct and regress on its own. That's why some people don't always advocate sectoral PRP in these cases, although most of the people I know that treat sickle cell do. Here's a good mnemonic: peripheral neovascularization differential, fires of Thor. You know the typical ones, sickle cell and diabetes. But fever, I showed a picture of that earlier, incontinentia pigmenti, ROP, Eales disease, sickle cell, which we're just going over, talc, retinopathy and IV drug abusers, hyperviscosity syndrome, ocular ischemic syndrome, and then retinoschisis. I had a patient with retinoschisis related in VE when I was a fellow. Only one so far. So the management of sickle cell. Remember sickle cell in those patients with hyphema, good IOP control, early AC washout, avoid carbonic anhydrase inhibitors, maintain hydration and oxygenation, and use an anesthetic without epinephrine. Avoid encircling scleral buckles. Don't detach rectus muscles. Light PRP of non-perfused retina may reduce the risk of vitreous hemorrhage, but does lead to retinal tears more often than does PRP for PDR. Anti-VEGF injection for hemorrhage precluding laser. Eales disease, tough one. It's a diagnosis of exclusion, typically in otherwise healthy males, young to middle-aged, associated with a tuberculin hypersensitivity, and Mycobacterium tuberculosis DNA has been detected in the aqueous by PCR in some of these patients. Peripheral retinal vasculitis, commonly a periphlebitis. They may develop venous occlusion, peripheral non-perfusion, VVH, and or tractional retinal detachment. I think that's supposed to say. Okay, next up. This is a patient that came in when I was a fellow. This patient is 24 years old, had headache, left leg numbness, then psychotic symptoms, admitted, was diagnosed with MS, had an allergic reaction to Avonex, and then was readmitted, given a diagnosis of ADEM, which is, I think, acute disseminated encephalomyelitis, but I think I'll have it up at the slide in a moment. And then we got consulted because of some vision symptoms. So, oh man, I was supposed to say what causes a clinical triad of encephalopathy, sensory neural hearing loss with tinnitus and BRAOs. It's Susac syndrome, also known as secret syndrome. Susac was the person who first described it. Secret captures the mnemonic, well, whatever you want to call it, the findings: small infarcts of the cochlear, retinal, and encephalic tissue. Can't just say brain because you got to have a good mnemonic. Otherwise, it'd be immune-mediated occlusive microvascular endotheliopathy. That's the age range. It's usually females. This guy was a man. These are gas plaques that he had, yellow arteriolar wall deposits. Most patients do not display the entire triad at disease onset. The differential includes what he was already diagnosed with: MS, the ADEM, herpetic encephalitis, sarcoidosis, Behçet's. So usually they've got a long list before they get to you. Here's a gas plaque again. And these MRI findings are pretty interesting. They look a little bit like MS, but they're a bit different. You see these multifocal hyperintense snowball type lesions within the central corpus callosum, which you can see right there. Almost pathognomonic depending on the neuroradiologist that you talk to. And so IVIG and all the stuff. So high dose steroids. Irvan, still haven't seen this yet in my entire career. Name includes the most salient findings: arteritis more than phlebitis, and you can get non-peripheral capillary non-perfusion. Oral prednisone is little benefit. Okay, CME, we've all seen CME. We've seen a bazillion slides of it just today. IRF, seen on OCT, you can get it after cataract surgery, uveitis, diabetic retinopathy, RVO, RP. And usually if it's retinitis pigmentosa related, we usually try topical or oral carbonic anhydrase inhibitors. Otherwise, NSAIDs and steroids. If they're non-leaky, meaning they have CME, but then you do a fluorescein, they don't leak on the fluorescein, then you have to think about some other things. And there's a mnemonic for this. It's older than me, and it's Young and the Restless Youths. Well, I added the AT&T, but that's the least important part of it. So juvenile X-linked retinoschisis, Usher syndrome, nicotinic acid maculopathy, Goldman-Favre, RP, Abraxane, Taxotere, Taxol. Those are like microtubule inhibitors. Well, I don't know if they all are, but Abraxane is. Yeah, it's like an albumin-bound version. Anyway, doesn't matter. Microtubule inhibitor. Coats disease. Picture we saw earlier today. You see these light bulb aneurysms along arteries, dilated arteries and veins with telangiectasia, intraretinal and subretinal lipid exudation, exudative retinal detachment, capillary non-perfusion. Rarely have posterior segment neovascularization, though. Leukocoria may simulate retinoblastoma. You don't want to miss that. And what do we see on histology of SRF? This is, I think, a test question in the back of the book. Foamy histiocytes, cholesterol crystals. Also, typical age of onset, young or old? Young, 6 to 8 years old. Unilateral, bilateral, usually unilateral. Male or female? Almost always male. So if they present a case to you, it's bilateral, it's in a woman, it's probably not Coates. Not for test-taking purposes anyway. Prognosis, treatment, severity, and rate of progression are greater in children less than 4, so the earlier it's diagnosed, the worse it is. Treatment can be a lot of different stuff: cryo, laser, sometimes surgery. It's a beautiful picture from Dr. Benson. Differential includes some important things: fever, fascioscapulohumeral muscular dystrophy, ROP, retinal hemangioblastoma, retinoblastoma. And milder Coats disease can look like diabetic retinopathy, BRVO, IMT2, radiation retinopathy. I've seen it misdiagnosed when it's mild. Coats-like reaction can happen in retinitis pigmentosa. Okay. Also seen with VPT, vasoproliferative tumor. Okay. So macular telangiectasia, it's got a lot of names. It's been around for a while. Nobody really understands this, so it gets more names. Kind of like CSR had a lot of names for a long time. Macular, juxtafoveal, parafoveal telangiectasia. We're going to call it MacTel. There's 3 types. There's really only one you need to know about, and it's not MacTel 1. This one is unilateral, occurs in young males, aneurysmal dilation of temporal macular vessels. This can look a lot like Coats disease. Yeah, some people think it is a variant of Coats disease. May have peripheral vascular changes. VEGF inhibitor is ineffective. MacTel 2 is the one you need to know. This is the one you'll get tested on. So much more now than in the past because of OCT. So it's the most common form. Usually it's in the 5th or 7th decade. They oftentimes will have diabetes. That's not in the book, though. They're also at risk for macular neovascularization. Mueller cell defect is one of the theories. There's a blunted foveal light reflex, superficial retinal crystals. Here's those retinal crystals again. Mildly ectatic capillaries. Here you see some loss of retinal transparency, kind of looks gray. Here you see some pigmentary changes, loss of ellipsoid zone, foveal atrophy, this cavitation in the outer retina. Inner retina with ILM drape, some focal ellipsoid zone alterations, and here's some pigmentary hyperplasia. And they kind of stain and leak a little bit. It's not a clean picture typically. MacTel 3, I'm not actually sure if this is what this guy has. He's a patient of mine from years ago. It's usually bilateral acquired. This guy was just unilateral. Extremely rare vasoocclusive process, results in retinal capillary obliteration. So maybe that picture's not appropriate. Maybe I have never seen it. And then we're going to hit a few phacomatoses associated with retinal vascular disease. Von Hippel-Lindau, we used to call these something else, but now we call them retinal hemangioblastomas. They're located in the retina or on the optic nerve. Spherical orange-red tumor fed by dilated tortuous artery and drained by engorged vein. So you got big artery, big vein. Don't forget that. May have subretinal fluid, exudates exuded retinal detachment. Often flat if they're on the optic nerve head. Difficult to identify. The chance of bilaterality is 50%. Mode of inheritance, autosomal dominant. The Q is in the familial part of the name. I didn't give you the other name. Familial cerebelloretinal angiomatosis. This is a patient I saw a few months ago in New Mexico. Already had her diagnosis when she came in to see us. She'd already had a systemic workup. She'd had multiple systemic associations, and that's true for these patients, for many of them. Hemangioblastomas of the cerebellum, medulla pons, and spinal cord. Renal cell carcinoma, pheochromocytoma, really bad stuff. Papillary cystadenomas of the epididymis, broad ligament issues. Here's one on the optic nerve. Can't treat this with cryo. This would be a hard one to treat, period. Laser, PDT, radiation, some other options. Destroy the lesion early is better. Causes of death are usually renal cell carcinoma, cerebellar hemangioblastoma. Another entity here, Wyburn-Mason syndrome. This is usually sporadic inheritance, congenital AV malformation. No intervening capillary bed. The vessels are engorged, but there's no tumor. There's no mass. And Wyburn-Mason syndrome, racemose hemangiomas with similar vascular malformations in ipsilateral brain, face, orbit, maxilla, and mandible. Watch out for bleeding during a dental extraction. That could be in a question stem. And then they're usually isolated without the whole syndrome. And retinal cavernous hemangioma. These do look different. Grape-like clusters. They get this erythrocyte, plasmacytic. Or here, we'll get to it in a second. On the FA, I'm getting tired. They have this kind of layering out of the red blood cells, and we'll see that in a moment. Most cases are sporadic and confined to the retina, but they may occur in an autosomal dominant pattern and be associated again with intracranial and skin lesions. Intracranial hemangiomas may lead to seizures, hemorrhage, and even death, so you should always have neuroimaging done. Here's that FA I was talking about. No leakage on FA, and then they get this plasma erythrocyte layering. That's what I was looking to say. On FA is pathognomonic. It's pretty cool. All right, here's another patient of mine, 51-year-old female, no history of diabetes, but she does have thickening. She's 2400. This, if you just show me this picture, 9 times out of 10, it's going to be diabetic macular edema. In this case, it's radiation retinopathy. And this is what her FA looked like. So I think that was hers. Yeah. Microangiopathic changes that resemble diabetic retinopathy. They can also get acute optic neuropathy, typically seen 18 months after exposure to external beam radiation. It happens earlier if they have local brachytherapy. Okay. And you can get changes even with a minimal amount of gray, 15 gray. 50. I'm not sure if it's worth memorizing any of these numbers. Certainly don't need to have memorized once you're a retina doctor. How many gray did you have, man? Well, you only had a 30% chance of getting macular radiation retinopathy. So VEGF-IN steroids may be effective treatments, but they're currently being studied in our DRCR retina protocol AL. So what's your diagnosis here? We see blood in multiple layers, blood probably pre-retinal like sub-ILM and definitely subretinal. We mentioned earlier a RAM could do this, but there's something else they could do is Valsalva retinopathy. This is a 38-year-old periodontist who had been moving furniture back in 2005 when I saw him as a first-year resident. I think this is my first Grand Rounds presentation. So you see the old OCT was not even slightly helpful. Nobody got it back then. All right. And then Terson syndrome, intraretinal sub-ILM subhyaloid or vitreous hemorrhage caused by an abrupt intracranial hemorrhage. So now we've got, we had RAMS, we had Valsalva, we have Terson's caused blood on multiple layers. So here's a patient that I was removing blood on last fall from Terson syndrome. Oh, that's some really bad news. She had a big submacular hemorrhage. That was the first eye I operated on. She was 2200. Second eye, thankfully, almost no, in fact, there was no submacular hemorrhage. There was a tiny bit of subretinal hemorrhage just around one of the arcades. She was 2025 post-op day one of the only patients I've ever operated on that cried with joy the day after surgery. So really thankful. She went from wheelchair to walking to her post-op month 1 visit, all because of her vision. Okay, so Percher retinopathy follows acute compressive trauma of the chest or head. Cottonwool spots are polygonal areas of retinal whitening, hemorrhage, and edema surrounding the disc, and it's injury-induced complement activation, leukoembolization, granulocyte aggregation, lots of big words. FA causes leakage and arterial obstruction. With Percher Flecken, that's these white things, you get intraretinal whitening with a clear zone on either side of the retinal vessels. So that's kind of one of the cool features. When you start to see this clearing, that kind of fits with Percher Flecken. Here's more Percher Flecken again, kind of clearing along blood vessels there and there. So Percher-like retinopathy is basically when you have conditions other than acute trauma that result in that same Percher-like picture. This is a patient we had at UT last year. Extensive workup, never found a cause, unfortunately. So there is a differential. I used to have a ridiculous mnemonic. I think you should just know a few things. Renal failure, fat embolism, lupus, pancreatitis, those other things are important too, but you're going to do a thorough workup. So good. All right. Thanks, everybody. And remember, wear your eye protection. Bye-bye.